Hi everyone, welcome to Ask the Egg Whisperer. So happy to be back here reading your questions. If you have a question, go to asktheeggwhisperer.com. My producer Paula, she'll email you the day that I'm going to answer them so that you can be sure to tune in. You can live chat with me as I'm answering your question, or you can also tune in later because after the show, don't worry, it'll sit here on Instagram and she'll send you a link so you can watch it later if you want. So I'm going to start off with my first question, and the first question is from Emily. And Emily is from Kentucky, and she says, "Hi, Dr. Aimee. I was diagnosed with endometriosis following hysteroscopy. I have a known bicornuate uterus, and I'm a from genetic screening, my husband sounds really kind of cute, was found to have MTHFR, and I am also a carrier. I was able to conceive immediately following surgery. I started spotting and ended up with a miscarriage following a normal ultrasound at 10 weeks. My immune panel and pathology on the tissue was all normal. Will having a bicornuate uterus lead to recurrent loss? Initially, my reproductive endocrinologist said he did not recommend repair due to the possibility of developing scar tissue. I'm at a loss here. Thank you, Emily, for answering your question. So when it comes to a uterine malformation, I always also want to know a lot about the cavity, and the fallopian tubes. So it sounds like you had a hysteroscopy, but I bet you also probably had a laparoscopy too. So at the time of laparoscopy, what you want to ask is, what did you guys notice about my fallopian tubes? If they actually didn't do a tubal dye study or flush your fallopian tubes with something like indigo carmine or methylene blue, it might be worthwhile to ask for an HSG. Women who have a uterine malformation like a bicornuate uterus are also at higher risk for endometriosis. That is true. So guess what? You already told us you have endometriosis. So it may not be a bad idea to talk to your doctor about how severe your endometriosis is, whether you should preserve your fertility now at your young age of 30 and make some embryos so that you can then go on to have more options for the future. Because we know when it comes to endometriosis, things don't often get better. It's kind of like catch-22. It's like, you know, if you get pregnant, then it treats your endometriosis. But when you have endometriosis, it's hard to get pregnant. And the other thing with your bicornuate uterus, when they did the laparoscopy, I'm assuming that's what they had. You want to also know if they did the hysteroscopy. I know you said you had a hysteroscopy, but I'm wondering if maybe you did both. And then ask your doctor, are you sure it's a bicornuate uterus and not a uterine septum? Because when you have a uterine septum, one of the symptoms could be a biochemical pregnancy or a miscarriage. And so that's something that sometimes gets, not the word is confused, but sometimes people are labeled as having a bicornuate uterus when they really have a septate uterus. You see what I mean? It all sounds very confusing, and it is. And you had a laparoscopy, so we know that they actually looked at the top of your uterus. So be sure to get your images from your surgery. I would go to a fertility specialist, sit down with them and say, have you ruled out adenomyosis? Have you ruled out a uterine septum? And then your husband's MTHFR status isn't really going to be a big deal for what you're going through right now. So I'm glad you brought that up, but I don't think that that's necessarily going to play a role. So if you're a patient of mine, that's what I would say. So long story short, to answer your question, yes, I do think a uterine malformation can get in the way of a healthy implantation. When I have a patient that has a bicornuate uterus, I always tell them you need more embryos, maybe 2.5 more embryos per live birth, and that's the reason is because you might get increased risk of having miscarriage, preterm labor, and preterm delivery. You're only 30, so I would suggest making embryos. Whew, okay, good. That was a good one. Thank you, Emily, for asking that question. Oh, it's hot in here, and I'll tell you why it's hot in here. It's hot in here because the furnace in the building went out. So we walk in this morning, it's 55 degrees. So what do? I get 5 space heaters and I put them on. I put them on in the whole office. Now it's 95 degrees in here. It's very hot. Okay, next question is from Jamie in Illinois, age 31. Hi, Dr. Aimee. I recently had a miscarriage during my first pregnancy, DNC, at 11 weeks. Baby stopped growing at 9.5. I had a healthy ultrasound at 8 weeks. Size and heartbeat were normal. HCG levels were normal. Ultrasound picked up a small subchorionic hematoma. No bleeding or physical signs of miscarriage. After the DNC, genetic testing revealed no chromosomal abnormalities. Where do we go from here? Is there nothing to be done at my age and with my history of recurrent loss? Okay, and you're also sharing that you're feeling totally lost. And Jamie, this is why I created the ANGEL workup or ANGEL checklist or ANGEL method. Basically, I want you to look at your AMH and see what your AMH levels are. A lot of times when miscarriages happen, they happen because the chromosome was not the chromosome. hello, McFly. The embryo was not genetically normal. So anytime you have a pregnancy, that's like the best diagnostic test that you could do that will teach you as to what's going on. So if you didn't have the opportunity to test the pregnancy and test the chromosomes, that's okay for those of you who are listening. But since Jamie did that, it sounds like we have to look at other things. So AMH, just to see where you're at your age, I think that's important. Then the next thing would be to look at anatomy. So look to see if there's a uterine septum in your uterus that could potentially be removed. That is not an uncommon reason for having miscarriages, especially at the gestational age that you have them. The other thing would be to look at an autoimmune panel to look for things like antiphospholipid antibody syndrome. Also look for a thrombophilia. Ask your doctor, I'm always saying this stuff. Have you ruled out endometriosis? Have you ruled out adenomyosis? As adenomyosis can be a reason to miscarry embryos that have normal chromosomes. And then also talk to your doctor about taking progesterone. So I think progesterone is something that I think of like water to a marathon runner, right? So you never run a marathon and don't drink water. That would be deadly, like really bad. So progesterone basically means promote gestation or implantation. And so, there's really no such thing as too much unless you take so much that you feel dizzy. And that would be bad. So then there is such a thing as too much. So for you, Jamie, I would suggest that you do a cavity evaluation, talk to your doctor about your fertility levels, how old you are, your family size goals, and then sometimes I also look at sperm quality and do a sperm DNA fragmentation test. But fertility docs like me, this is what we do. We take care of patients just like you. So I know while some people think that seeing a fertility doctor sounds weird, like you're not having a problem getting pregnant, your problem is staying pregnant, but that's our thing. Like we're here to help solve those problems as well. So I help people who are fertility curious, people who are trying to get pregnant and are having a hard time, and people who are pregnant and having issues, or people who are having recurrent miscarriages. So I hope, Jamie, you're in Illinois. There's so many great doctors in your area that you find one very soon if you haven't already. This next question comes from Jen, age 40 in the Bay Area. Can letrozole mess things up if you take it in the middle of your cycle instead of day 3? After my 22-week loss in June of 2020, my period never returned. So after 4 months, I took letrozole, and that finally made me ovulate, and I turned 40 during the wait. 2 weeks ago, I had an 11-week miscarriage because my doctor abruptly took me off progesterone without testing my levels. Took the baby with me into the ER for testing, and there were no chromosomal abnormalities. I'm scared my period won't return on its own again. How soon can I take the letrozole? Or as soon as my HCG goes to 0, or do I have to wait for my period? What would happen if I took it, but my body's about to ovulate on its own? So Jen, here's the easiest thing to do. I would get tested. Check your HCG, get an ultrasound done post-miscarriage, kind of see where you are in your cycle. So if you're a patient of mine, it didn't look like there was any period in sight or ovulation and your lining was nice and thick, I would basically induce a period with either birth control pills or progesterone. Kind of start off with a clean slate and then start Femera, right? You don't have to just wonder, is it okay to start right now? You can simply go in, get seen, get an ultrasound, get some blood work, and then start from there. So I totally get it. And of course, I'm extremely sorry that you've had to go through this, but it does make sense to start right away. I don't feel, medically speaking, for my patients that it makes sense to wait months and months. And I hear this recommendation by sometimes well-intentioned folks. They're like, oh, just wait, 3 months or 6 months. And at the age of 40, as you probably feel, and it's the same thing that I would feel, if I were in your shoes, waiting 3 to 6 months to start trying again doesn't make sense. And at the same time, given what you've been through, this is now the second loss that you've had, a 22-week loss and 11-week loss. I would strongly suggest seeing a fertility doctor. And it sounds like you might be, since you're taking letrozole, but you might also just be seeing, not just, OBGYNs are fantastic and amazing, but you might be seeing an OBGYN. But I would highly recommend that you consider being as aggressive as you feel comfortable being. And if doing IVF, for example, and creating these embryos now, and then doing some studies on your uterus is something that you would be open to, that's what I would consider doing. And talk to a doctor about what they've ruled out and what they can do to help you stay pregnant with this next precious pregnancy. Okay, this next question comes from Nisha from Washington State, age 31. What are the chances of me getting pregnant after a miscarriage? We've been trying for over a year, my husband and I, and we're having no luck. Any suggestions? So the chances are still pretty good at 31, assuming you have healthy fertility levels and your fallopian tubes are open. But I would make sure that you've done the 5 fertility tests that I often talk about, and that's part of my Tushy method. So get your fallopian tubes checked at the same time you can have your cavity checked, have a pelvic ultrasound done, look at sperm quality again. You can't just assume that a year ago everything was fine and that right now it still is. So I would look at that. Check your AMH, your FSH, estradiol, do preconception labs like your TSH and vitamin D and prolactin. And last but not least, make sure you've done some genetic testing to make sure you and your partner are genetically compatible and that you don't either of you have a chromosomal abnormality. So I know I just rattled off a whole bunch of stuff, but it's actually quite easy to do just in one menstrual cycle. So your period starts, you go on cycle day 3 for all the hormone levels in your genetic carrier screen, then do an ultrasound right before your HSG on cycle days 8 through 10. And by the time your cycle is over, you have the sperm analysis test, and you can do the sperm analysis at home with a DIY kit like Meatfellow, there's Legacy, there's so many companies out there that are doing a really good job telling guys how fast their swimmers are. You can have all your results back and a plan, so you don't have to sit there and wait and be like, what should I be doing next? And why is this not working? So that pregnancy had a lot to teach us, and that taught us not to give up and to keep trying. But at this point, that pregnancy is also telling us it makes sense to start doing some more testing without waiting. Okay, this next question comes from Katie, age 30 in North Dakota. I have Turner syndrome, and as a result, my ovaries are underdeveloped and I have no eggs. My husband and I are going to do IVF using donor eggs since I have cardiac approval. A big question on my mind lately is if I should get my ovarian tissue removed to reduce the risk of cancer in the future. And who should I discuss this with? My RE, OBGYN, or my PCP? Thanks. I'm loving your show and the information you share. So Katie, I think this is a really, really great question. I'm not concerned about your risk of ovarian cancer given that you have Turner syndrome. That's not something that has me concerned. However, if you have a family history of, let's say, ovarian cancer, or colon cancer or breast cancer, I highly recommend anyone who's concerned should have a cancer gene screen done. I think the stats are something like 1 in 279 people are carriers for the Lynch syndrome gene, and only 5% of people know it. So if, let's say, on either side of your family, especially immediate family members, they might have a history of breast, ovarian, colon, or any other type of cancer. And honestly, if you're just worried about it, I think getting that screen done is very easy and straightforward to do. So when you're a patient of mine, guess what? You come in here for your carrier screen for the recessive genes, and I just check a second box that tells me, that tells the company, not me, I already know, that tells the company to also check your cancer genes at the same time. And then we get both reports back when you review them and make a plan. And as far as who to talk to about this, I would suggest talking to everybody, your RE, your OBGYN, and PCP, and see what they say. And they might refer you to a GYN oncologist to give you an expert opinion if you have more questions. This next question comes from Karen, age 49 in New York. She says, hi, I would love to know your recommendations about PGT with donor eggs and older sperm. I'm 49, my husband is 59, and presumably the donor will be in her late 20s. I have no known fertility issues, just waited too long. My partner's semen tests were good and he has 1 teenager. I did have 2 chemicals with my own eggs at 43 and then became a foster parent now. I'm hoping to move forward with donor egg as quickly as possible, so testing seems like a good idea. I'm concerned about the possibility of damaging a good embryo, false negatives, delay in transfer, etc. I'm not sure my clinic's policy on mosaics, but interested to know if you'd suggest transferring those if needed. Not concerned with gender, and my clinic has reasonable fees, so neither of those are factors. Not sure yet regarding a second child. That will depend on how this pregnancy hopefully goes. Everything I read is about 50-50, so I'd go back and forth. Thank you. Love your upbeat spirit. So Karen, my answer to you is yes. I would definitely have you consider testing. Why? It's because the paternal age is over 50. Men who are over 50 have a higher chance of having embryos that have more chromosomal abnormalities than men who are under the age of 50. There are a few tests that you can do. You know I've talked about doing a semen analysis, so you can do that through, let's say, Meatfellow. You can also do something called the Path Fertility Test. That will tell us if your husband's age is, or I should say his sperm age is older than his chronological age. If, for example, his sperm age is a lot older than his chronological age, then you know that potentially you could be facing more of a challenge as far as getting healthy embryos. If his sperm age is lower than his chronological age, well, I can tell you that's quite reassuring, at least, you know, if it were me. We also know that along with paternal age comes an increased risk of other diseases. I'm sure you read them all and heard about them, so I'm not going to share them with you right here. But I think it's so important for guys who are especially over the age of 40 to take incredible care of themselves, get into the best shape of their lives, especially 3 months going into that thaw date. And make sure you've done all the testing, you know, eat healthy, sleep well, exercise most days of the week, avoid hard liquor, no marijuana, no cigarettes, vaping, no fun stuff. Sorry, but not sorry, because it's worth it. But my recommendation would be to test in a situation like yours. So that's what I think. And then the other thing that I do as people are preparing for their embryo creation, I talk to my patients about implantation testing, and we do tests like the ERA and the receptiva, just get them out of the way so that once embryos are here and ready to go, then we go for it, and we don't have to have any further delays. Okay, this next question is from Mariana, age 43 in the US, and she says, "Hi, Dr. Aimee, thank you so much for making so many helpful videos. I need your help to decide which prenatal to take, one with folic acid or one with folate. I've been taking one with folate and glucosamine from Care of, and I recently read an Instagram post from a doctor who mentions that folic acid is the only type of folate shown to help prevent neural tube defects. The doctor also wrote that no scientific studies exist that show that supplements containing other types of folate, such as 5-MTHFS, can help prevent neural tube defects. Should I change prenatals and look for one with folic acid? If so, how much folic acid should the prenatal have? Thank you so much." So Mariana, I honestly think that it doesn't, you just have to get folic acid, whether it's folate or folic acid. And some people say folate is better, but I think honestly, it probably doesn't matter. But the trend is that most prenatals nowadays actually have folate in them. And I don't think you have to discriminate against a prenatal that has folate to move over to one that has folic acid. And you know that saying, I know, you're going to be like, food is medicine. Ta-da! So you can actually get much of your folate that you need from your green leafy vegetables, and you don't have to rely on supplements. So if you're eating a well-balanced diet and you're paying attention to how much folate you're consuming, you can rely less on supplements. However, some days, some people eat less salads than other days. So then on those days, of course, it makes sense to take more supplements. I would say I typically recommend about, I think it's 2,000, I'm going to screw up the units, 2,000, I think it's micrograms of folate per day. I think that's what my favorite prenatal has. I would zip over to my phone and look it up real quick, but I'm on my phone, so I can't do that. It's like when you're looking for your phone and it's up to your head and you're like, where's my phone? And you're like, oh, it's here. So that's my thoughts on folic acid. So the prenatal that I like a lot is the Theranatal prenatal from Theralogics. And if anyone wants, you can use the code TUSHY, all caps TUSHY. Good thing I spelled it, and you can get it from that website. The next question comes from Sadie, age 31 from Washington State. "Hi, Dr. Aimee. Thank you for giving me so much hope, and so much hope to all those suffering from infertility. My question for you is, gosh, today is an MTHFR popular day. Here we go. What are your thoughts on IVF and MTHFR, the methyl tetrahydrofolate reductase gene mutation? I have this gene. I'm 31 years old and husband's 32, and we just underwent all the Tushy tests. Awaiting results. I have stage 3 endometriosis with one blocked fallopian tube and no success getting pregnant on our own. We will be starting IVF soon. What would you recommend or suggest for success? We would like 2 children." So Sadie, what I'll say to you is having the MTHFR mutation is very, very common. A lot of people have that variant. I don't think it's a big deal. The only time I think it's a big deal if you have an eating disorder and you're just not eating anything that contains folate. So people who are bulimic, people who, bulimia, anorexia, and one other thing is I've actually, people who have some, I was thinking about a scenario, people who have substance abuse disorders, meaning you're not eating and you might be drinking more alcohol. I think sometimes your homocysteine can be elevated because you're not getting as much folate, and that's when you get into problems with hyperhomocystinemia, and that's something that you can have checked. So if you're worried that you're not getting enough folate, simply get a fasting homocysteine level checked. First thing in the morning, you can drink water, no food, and see if your homocysteine is less than 8. If it's less than 8, you're great. If it's over 8, then you got to get more folate. That rhymed, you guys. That was pretty awesome. Okay. So as far as what's going on with you, Sadie, what I would recommend is this. With stage 3 endometriosis and one blocked fallopian tube, I would say this. Get your embryos created and then go back and ask your doctor if you're at risk of having an ectopic pregnancy. Have them talk to you about whether it makes sense for you to do an HSG before you transfer. Here's why. You had surgery for stage 3 endometriosis. Even if God touches you, you can have scarring of your fallopian tubes, right? So we already know a fallopian tube is scarred, and I would hate for you to have an ectopic pregnancy after an IVF cycle. So, going through everything you're going through, and I live through this every day, unfortunately, with my patients, is you do things and you hope for the best and you've done everything you possibly can, and then sometimes things happen that are completely out of your control. And one of those things that can happen is a pregnancy that you put in the uterus and somehow it just decides to not stay there. And that can be a pretty crummy day. And so when you have stage 3 endometriosis and you have already a diagnosis of a blocked fallopian tube, then we know that you're at higher risk of having ectopic pregnancy because the tube is there and it's a little bit abnormal. And if that embryo goes into the tube, that embryo will not be able to be like, go back home. That tube will be like, I can't get you home. I'm stuck here. And that's how the tube talks too. I'm not sure if you knew that, but tubes talk just like that, exactly like that. So that's what I would recommend that you do. And then consider maybe taking Depo-Lupron, for example, if your doctor thinks that you have mild or moderate or any type of adenomyosis. So talk to your doctor about that too. Okay. This next question comes from Nessa, age 30 in California. Hi, Dr. Aimee. I'm 30 years old, was diagnosed with endometriosis, and I had excision surgery 5 years ago at the age of 25. At 28, we were blessed to conceive naturally in 4 cycles, even with AMH of 0.2 and FSH of 14. Sweet. I'm still breastfeeding my daughter, and we're trying to conceive number 2. What do you think our chances are to repeat the same fortune? And how long should we allow ourselves to try before we need to take the next step? IVF is really our last resort and probably wouldn't be very effective with my AMH anyways. Are all the supplements you recommend safe while breastfeeding? What is your recommendation for our situation? Okay, here's the deal, Nessa. I would definitely take CoQ10 as soon as possible if you're not already. Stay on it until you're done having your kids. You can get CoQ10 from the Theralogic website. The NeoQ10 is my fave, and you can use code TUSHY. Again, you want me to spell it, don't you? All caps TUSHY. See, good thing I spelled it. But my answer is this. I would repeat your AMH and also repeat your FSH. And then see what's going on. See a doctor, get your follicle check done, see how many follicles you have. And I would say if you have 3 or more eggs that you could potentially have retrieved, I would start doing IVF. I don't want you to miss an opportunity to have another baby with your own eggs. I've been here before with other patients, and I would say if there is a chance that you would consider IVF, I would do it now. Doesn't mean you need to use those embryos right now. You can certainly try naturally after you do the IVF and still get pregnant naturally and save these embryos if you want a 3rd or 4th baby. And I would applaud you if you did that, because I feel like there's nothing more selfless than having children at this point in time in our world, at any point in time, but especially now. I have patients that say, Aimee, I just feel so selfish wanting a baby. I'm like, choo, 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 choo. No. It's not selfish, it's selfless. I mean, having children makes you poorer, makes you retire later, makes you look forward to your grave. I'm just kidding. But in all seriousness, there's nothing selfish about having children, especially in this day and age. Okay, so anyone who's thinking that for 1 second, zip it. We're not going to talk like that. You're just going to talk about how selfless you are, how giving you are, how amazing you are for, stabbing yourself. I mean, there's no one else out there that I know, except all my patients, that would stab themselves literally in the butt for 3 months, if you think about it, for a chance for a healthy baby, right? And that's called selfless. There is nothing selfish about doing that. Okay. This next question comes from Allison, 38 from Philadelphia. Hi, Dr. Aimee. I'm doing Nessa, one more thing for you. One more thing. Not that you didn't ask me. I would, if you don't want to do IVF, it's okay. I would be as aggressive as you feel comfortable being. And sometimes that means just taking fertility pills to help you ovulate more than 1 egg. So maybe you'll ovulate 2 eggs and you will get pregnant naturally at home. At the age of 30 with an AMH of 0.2, I would say your chance of getting pregnant per cycle is probably, around 5 to 8%. It is definitely not 0. So I still think that you have a pretty good chance getting pregnant naturally at the age of 30 with an FSH that's 14 and an AMH of 0.2. But I don't want to take anything for granted, because I feel like, as you can imagine, with all the questions that I answer here and talk about here, you just never know what's going to happen, as far as what your levels will do. So I would definitely repeat your levels, since it looks like you had endometriosis, at age 28, those are your levels. And I would also probably consider doing an HSG too if you guys don't get pregnant pretty soon here, because we know that endometriosis can affect your tubes and you had that surgery done. Whew. Okay, next question comes from Allison in Philadelphia, age 38. Hi, Dr. Aimee. I'm doing my first IUI round this cycle with meds. After the procedure, do you have any recommendations, nutrition, lifestyle to help ensure success? Okay, so after the IUI, I would say, no, I'm just trying to be funny and I can't come up with something really funny. I think the most important thing to do is know that you've done everything that you can. At the end of the day, IUI has not the highest chance of pregnancy. Doesn't that sound kind of negative? But it's not meant to be negative. So your chance of IUI success at the age of 38 is around 10 to 15%. So if it doesn't work, you have to remember that it's not your fault. It's because 1 reason and 2 words. You're human. I don't know if that's 2 words. Maybe it's 3. You are only human. 4 words. And humans are really, we're really bad at getting pregnant. And IUI is just, you would think, like you put, 40 million sperm cells, like 2 centimeters away from an egg. You would think that like people would get pregnant like 100% of the time, but it just doesn't work out that way. And that's slightly more than annoying. That's very, 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 very extremely annoying. So my recommendations are eat healthy, a well-balanced diet, avoiding processed foods. The questions people ask me are, can we have sex after the IUI? The answer is yes. Can you exercise after the IUI? The answer is of course yes. I would say just live, be as healthy as you can possibly be. And then the only other thing to consider doing is, take CoQ10 if you aren't already. Add progesterone if your doctor thinks that's right for you. Make sure you've done the Tushy check if this IUI doesn't work, and I hope that it does, so that you can learn more about your body and see that you're making sure that the treatment that you're doing is going to treat the diagnosis that you have. And sometimes people do IUI because the sperm's not good, and I'm like, how is IUI going to help? If the sperm's really low, if the count is really low, IUI can't overcome that, and that's where you need to do Pixi. Or if one fallopian tube is blocked, then it might be harder to get pregnant with IUI if you're ovulating on the side that's blocked. You see what I mean? So make sure you're addressing the diagnosis with the treatment that you guys are doing. This next question comes from Lindsay, age 32 in California. Hi, Dr. Aimee. Thanks for being so funny and always willing to share your knowledge with us to help make our journeys a little bit easier. At least you didn't say, hey, Dr. Aimee, thanks for not having a bad hair day every time you're coming on and always, just kidding, because literally that's what it feels like. Thanks for being so funny. I love that. I'm wondering what the differences are between Pixi and Pixi and what each of them help for. Okay, so Pixi is where you take a single sperm cell and put it into the egg, right? I can't come up with a really good analogy right now. Pixi is one way of finding the really good sperm cell before you put it into the egg. So with both technologies, you're basically doing Pixi for both. But with Pixi, you're using this little dish for the genetically normal. I don't think sperm swim. That looks like a slithering snake. But actually, that is kind of how sperm cells swim under the microscope. But we're looking for the best looking sperm that's also bound to a certain part of this dish. And those sperm cells are the ones that have the highest chance of being genetically normal, because they tend to also be morphologically normal, meaning they're the most beautiful. They have the most beautiful shaped head. So that's basically Pixi. Pixi is a more stringent way of picking out the beautiful sperm before you put it in the egg through Pixi. And Pixi is you still look for the most beautiful sperm, but you're not using the Pixi dish to do so. You're just looking under the microscope to look for the sparkler. Sparkler, yes. I see sparkles. That's what I do when I look at sperm. Okay, so this is Christina, age 25 in Boston. Hello, I apologize in advance if this question has already been asked. No apologies needed, Christina. I keep getting targeted ads on social media for fertility tests, and of course now my interest is piqued. I don't plan on having children until I'm about 30. I'm 25 now. Do you see any utility in doing this test? I'm not sure how it would change my outcome knowing the results, having children earlier, freezing eggs, etc. Okay, Christina, you're 25, and every single 40-year-old woman that has walked in my office this last week is screaming at the top of her lungs. I can hear them. They're like, Christina, freeze your eggs. I swear to God, it's a different world now than it was 10 years ago, than it was 10 years before that. Before, freezing eggs was something that was associated with stigma and shame. It was like, oh, not me, not here. I've been shouting it at the top of my lungs, like, oh, she needed to freeze her eggs. And it's like, huh? Now it's empowering. Now it's all about securing future options for yourself. It's not about having an insurance policy. It definitely isn't. I mean, ideally, I want everyone to have a baby as young as they can possibly do that, so that they don't need any of this technology. But we know that the world is changing. I actually interviewed someone, I'm totally going off on a small tangent, very recently for the podcast. She'll be on in the next couple of weeks. But she basically had this incredible analogy. She said, human beings are part of an experiment, and they don't even know it. We're being poisoned basically every single day. And the poisons that are in the water, in the plastics, from the time we are in utero, are basically going to make it so that human beings will not exist as of what I think she said was like 2045. And I was like, holy smokes, that's crazy. So I do feel like, egg freezing is something that everyone should learn about, everyone should consider. Not everyone needs to do, but if you know my Egg Whisperer golden rules, my Egg Whisperer golden rule is if you're 32 years old and you think you want 2 kids, freeze your eggs by the time you're 32, like when I froze my sister's eggs. If, let's say, you're 25 years old, I would definitely get your levels checked. And then if your mom needed IVF to have you, if you have symptoms of endometriosis, if you had to have an ovary removed or have had an STD, STDs like gonorrhea, chlamydia, and we know that STD rates have surged in the last year, and that can block your fallopian tubes, and I would definitely freeze your eggs. If there's some sort of condition that you have that is fertility threatening and could cause you to need IVF, then I would say freeze eggs as soon as you feel ready to do so. So the answer is yes. I do think asking to getting your levels checked to see where they're at makes sense, and then talking to someone like me who will guide you based on what your goals are, your family size goals, your relationship status, when you want to have kids, how many kids you want. This is what I do happily and with joy every single day. I love, like my sister as an anesthesiologist, she's like, shh, I only like talking to you when you're asleep. Me, I'm like, I want us to talk. I want to learn everything about you. I ask questions that they're like, no one's asked me that question. I'm like, I know, but I really actually want to know that question. The answer to that question, not that question. I want to know the answer to the question. Okay, this next question comes from Christina, age 37 in Arkansas. Dr. Aimee, I know I've told you before, but thank you for saving the sanity of my partner and I by answering questions we didn't and don't know to ask and sharing information that we had no idea we were supposed to know. Mission accomplished, you guys. I can retire now because that is my goal in life. Literally, with a big fat L. I pray all practices strive to be as supportive as you and yours. I have the same prayer, Christina, and if a practice isn't going to be that way, I want to empower patients to know what words to use so they can get what they want. Because a lot of clinics, they don't allow patients to choose what's right for them. They're given no choice. So I have to teach patients how to know what is right for you by educating you about your diagnosis and what's available to you out there. Okay, my question is this. How does your practice handle insurance issues, medication ordering duties? We have been fortunate to be able to save for IVF, but trying to use insurance, obtain meds, and communicating with staff about this has been so stressful. If they seem overwhelmed with duties, should I speak up again to the physician? Is there someone who coordinates this aspect and streamlines it for your patients, or does this vary with all practices? My gut tells me this is unorganized, but I could be wrong. Any thoughts? So Christina, it is I was going to say a bad word. I'll tell you, it's kind of a shit show out there when it comes to insurance. And what I mean by that is you send stuff to insurance and they're like, we didn't get it. And I'm like, well, I sent it. I got a fax confirmation. You said you got it. And then they tell the patient, we got it and we didn't cover it. And then I'm like, well, you didn't say that. And then you call the insurance and they say, oh, I don't cover it. And I'm like, but you told me that you cover it. And they're like, well, we'll cover it, but we'll cover a different version of it. And you're like, but you told me it was a different version. And I can tell you that this back and forth can go on for weeks and weeks and weeks. So while it seems like your clinic may not know what's going on, trust me, they know. And they just have to deal with the paperwork and the admin stuff. And so every clinic does have their dedicated staff that helps with ordering. But if you're dealing with an insurance plan that needs prior authorization and they're going to pick and choose which medications they're going to use for you, imagine there's like 10 different medications that you use when you're doing IVF. And imagine you're saying, well, I want to use ganirelix. And they say, no, we only cover Cetrotide. Well, I want to use Follistim. Well, no, they only cover Gonalef. Well, I want to use HGH. Well, we don't even cover that. Well, I want to use HCG. Well, you have to prove first, if you're going to use this medication, that you failed this one, and this one. And then don't get me started when it comes to progesterone. Because there's a certain brand of progesterone that I like. And then they're like, nope, you have to use the one that you don't like. And I'm like, okay. So it is unorganized in that that's how it seems to the patient. But from the clinic standpoint, we do what we're supposed to do to get insurance authorization and get medications ordered. But those are my thoughts. But for the most part, patients who have insurance, there are certain pharmacies, like Encompass is one of them, and they're fabulous. So if you send the prescription to them, they do a lot of the insurance for you, and what they tell me is almost 100% accurate. So I'm not sure if that's a special little tip that you can ask your clinic to maybe send them to Encompass. But if you're required to use like Optum or CVS Caremark, sometimes a lot of that back and forth can create a lot of hassles. Okay, this next question comes from Stacy, age 35, in Pennsylvania. Hi, Dr. Aimee. I've been to Pennsylvania. I've been to Allentown, Pennsylvania. There's a whole bunch of Vasidays in Pennsylvania. So if you're named a Vasiday, you can imagine you're either a doctor or related to me or both. There's, I think, about 3, 4, 5 Vasidays in Pennsylvania, and they're all my relatives. Colorectal surgeon, orthopedic surgeon, physical therapist. I had an HSG done, and okay, sorry, I got too excited that you're from Pennsylvania. I'm remembering the chicken dance that we did at one of the fairs years ago. Now the song is in my head. Sorry, guys, for all of you guys who are now you have the chicken dance song in your head and you can't get it out. Okay. Okay, I have a question about HSG and a saline sonogram. 3 years ago, I was diagnosed with secondary infertility after trying for 2 years. I had an HSG done. I can't even talk right now. The tubes were open, but I had a terrible reaction the following day to the iodine. However, I went on a few months later to have a somewhat normal pregnancy. Now that we're trying for baby number 3, we're back and having infertility issues again. I do have an FSH of 13.8 and an AMH of 4.8. We recently saw a fertility specialist and she recommended getting a saline sonogram and an HSG. She did mention that I didn't have an HSG again, but she did mention that, I can't tell what that says, so forgive me guys. My question is this, do I need an HSG again, even though I had it 3 years ago and everything was fine? Won't the saline sonogram give the same amount of information? What's the difference between the two? I really don't want to go back and experience the HSG again. I hear you, Stacy. I mean, I think the only reason why I would say it makes sense to do an HSG again is if you potentially have a new partner. If let's say you've been diagnosed with an abnormal pap smear, maybe that's some sort of new exposure infection. If let's say you have symptoms of endometriosis or maybe there's something on ultrasound that she's concerned about that she's seeing, like some sort of dilated fallopian tube, and I'm not sure if that's something that she's expressed to you, then I would say, yes, it makes sense to do an HSG. And my thing is that some clinics still have these rules. They're like, if it's been over a certain number of months, repeat that test. And for some people, HSG is one of those things that you don't necessarily need to repeat every year, but maybe she's just being super careful and cautious and she just wants to make sure she hasn't missed anything. So I would just ask her, why are you recommending the HSG? And this is the other thing. Sometimes ordering the HSG is a lot easier for people than having you come in for a saline infusion sonogram. So when I order the HSG, you're going to go to an imaging center, right? Because I don't do HSGs here. They're done at an imaging center. Although I feel like I should do them because the stories I hear are like, I don't think that doctor's ever seen a cervix before. They're like, it took him an hour to find my cervix. And I'm like, okay. So anyways, I digress. As far as the saline sonogram, those are usually done by the fertility doctor, and everyone is like so busy right now with patients. And so that might be one reason they want to check out your cavity, but have you do it somewhere else and not in their practice. So that might be one reason they're recommending the HSG. The HSG has lots of benefits. It looks at the cavity and the tubes. I have a stuffed animal over there. That's a uterus stuffy. It sits on a little chair in my office. And the saline sonogram just looks at the cavity and not necessarily the tubes unless it's very obvious that there's a hydrosalpinx. I like the saline sonogram because I can also look at the ovaries and check out the number of follicles. I like the HSG because then it tells me if there's a hydrosalpinx and the SIS can't. So there is a benefit to both. So what you could do is do a regular ultrasound and an HSG. In the regular ultrasound, you can look at the follicles and then you can be sure to, that you're not missing anything with the fallopian tubes. Or you could just go with your gut. And if your gut is saying, I don't need the HSG because I don't have any of those risk factors that Aimee just mentioned about having tubal blockage. But I can tell you, I actually have had a patient before. I've helped her with 2 kids. And then I tried a few IUIs. I'm like, this doesn't make sense. Sure, you're a little bit older, but it doesn't make sense why it isn't happening as quickly as it did before. And sure enough, one of her, see, I can get that word out. One of her fallopian tubes is actually blocked on HSG. It's like, what were the chances? And I just thought, you know what? It just makes sense. Like, this isn't making sense why this isn't working. And sure enough, her freaking tube is blocked. Just one of them, though. So hopefully we'll be successful with her other tube that she's ovulating on. Okay, this next question comes from Catherine, age 30, from West Virginia. Hi, Dr. Aimee. I'm 30. Diagnosis is endometriosis. CA125 is 53.6. Tushy. That's a new one. Tushy and balls are all normal. AMH 0.9. My total testosterone is 8. DHEA 133. First IVF with Pixi, 11 eggs, temperature, 9 FERT, 3 blasts with no inner cell mass. Fresh day 3 transfer of 2 embryos resulting in pregnancy but miscarried at 6 weeks, 5 days. Second IVF cycle with Pixi, 10 eggs, 5 mature, 4 FERT, 3 blasts, but all abnormal, not mosaic. 2 days 6, both 5 CCN, 1 day 7, 5 BC. Sperm on the day of the egg retrieval was normal. Endometrial biopsy and saline sonogram normal. We both take CoQ10. He also takes fish oil, multivitamin, prenatal, DHA, aspirin, 81 milligrams. My doctor talked about Omnitrope for the next IVF. He does not recommend DHA supplement. This will be our final IVF cycle. Do you have any other suggestions? I do. Okay, so we have an embryo quality issue and you're very young at 30 and this sucks and I'm so sorry. So number 1, let's look at your lifestyle, your healthy habits and make sure that you're as healthy as possible, both you and your husband. It sounds like you're into that because you're both taking CoQ10, right? So with CoQ10, it comes with a caveat, must exercise daily. I'm just kidding. It doesn't. You don't have to exercise daily to take CoQ10, but I can tell that, you're asking all these questions, so you must be doing all those things, right? The other thing is I would look at sperm DNA fragmentation because I feel like that could be a reason why you have lower embryo quality than expected for someone who's age 30. So do that. The other thing is, obviously, I'm sorry, and I know I talk fast, and I don't want to make it feel at any time that I'm making light of anyone's situation or story, or that I'm mocking you because of some of the stupid things that I say that have nothing to do, like the chicken dance, that have nothing to do with your story and how seriously I take the situation you're in. But that pregnancy at 6 weeks, 5 days, that taught us something. That told us that you make a strong blast, right? Right? You make a blast that is strong enough to turn into a pregnancy. Well, that pregnancy wasn't normal. That embryo is there to teach us a story. So what is that story? The story is, what's the story? The story is, it's trying to tell me to rule out a chromosome abnormality in both you and your husband. Make sure that you guys, neither one of you, have a chromosomal abnormality. It looks like you may not because you did genetic testing of the embryos. You had 3, all were abnormal and not mosaic. So make sure you ask your doctor, is there a chance that, something should be checked for me and my husband to rule out that possibility. At the end of the day, it could be egg quality. That could be the issue. It could be sperm quality. It could be a little bit of both. But the genetic test that I would do would be a Fragile X screen if you haven't done it already, a chromosome analysis if you haven't done it already. It sounds like you have a history of endometriosis, and that's basically what I think probably is the title of our book. So endometriosis, and that's the fertility book. So endometriosis can cause less viable eggs, less mature eggs. It can cause, you see me doing this a lot when I'm talking, so it could cause the eggs of someone who's 30 to act older only because of endometriosis and what it can do. So it sounds like your diagnosis is made from a CA-125 level, so ask your doctor, does it make sense for me to do a laparoscopy for endometriosis? I think that's a really fair question. There are some studies that suggest that surgery for severe stages of endometriosis may improve IVF success rates. Surgical studies are really hard to do for many, many reasons, but only do surgery if you feel, let's say, you have symptoms of endometriosis, your quality of life is kind of crummy. So I think maybe doing surgery could help in a case like yours. Otherwise, be sure to repeat your AMH level, because one of the things that can happen if you have a cyst of endometriosis and they remove it, that could decrease your AMH and your egg count. But from what you're sharing with us, it doesn't seem like you have endometriosis inside your ovary, and that collection is called an endometrioma. So that's one thing that I would suggest. The other thing, you mentioned CoQ10. I would also have you consider taking N-acetylcysteine. NAC is a supplement that has been shown to slow the progression of endometriosis and cause it to regress as well. I haven't necessarily seen it myself that it's caused it to regress, but I do think that my patients who take it, just visually looking at their ultrasounds, maybe it doesn't grow as fast in my patients who take it compared to those who don't. So that's one little tip for you. And I would consider HGH. I would consider taking it now and maybe taking it for even 1 to 2 months before your IVF cycle. And in your IVF cycle, consider taking it every day to every other day. So that's what I would do. HGH, NAD, pterostilbene, NAC, get good sleep, do all that lifestyle stuff that I'm always talking about, sperm DNA fragmentation test, and then before you transfer again, do all my implantation testing. So all of this stuff I actually spell out in the word diet. The Egg Whisperer diet. Diagnosis, which it sounds like it's endometriosis that's causing poor embryo quality most likely. Then you're going to do your IVF, making sure that you're preparing and taking care of all the things that I just mentioned. You're going to do endometrial testing, knowing that you have endometriosis, and consider a laparoscopy, and then you're going to transfer. So I go through all this stuff as well in my Egg Whisperer school. So I do an IVF class every other Monday. Yes, every other Monday at 4 p.m. And I have so much fun doing it. And I hope you guys will join me there. This next question comes from Beth, and Beth is from Baltimore. Hi, Dr. Aimee. Thank you for taking my question. My AMH is 2.4. My tubes are open. I'm ovulating normally, and my progesterone levels show that, and my husband has great sperm. She doesn't say they're sparkling, but I think she meant to say that they're sparkling. We're scheduled to start our first IUI protocol this week. My doctor chose Clomid, Ovidrel, and Prometrium. How should I expect to feel after taking these medications? Can I skip the Prometrium? Thank you in advance. Okay, so first things first, Beth, Clomid sucks. It's horrible. So If you have a history of depression, migraine headaches, possible chance of endometriosis, decline Clomid and say, I think Femara would be better for me. That's what I would do if I were the patient or if you were a patient of mine, okay? Clomid, however, does work for a lot of people. A lot of people don't have the side effects that I'm mentioning, but no, I thought I saw a little mouse running around. Just kidding. No mouse here. It's from all the heat that I start seeing things like little mice running around. For those of you guys who don't know, the furnace in the building, it went out on Sunday, so we've been sitting around in space with space heaters around us all day. So it's about 95 degrees here, if you can't tell by what I'm wearing. So the question is, how should I expect to feel? Well, I think I basically told you. With Clomid, you could have hot flashes, night sweats, vaginal dryness, and a headache. Sound fun? No. So you have to know that these things are potentially coming, so you have a coping strategy to deal with each and every one of them. So for the headaches, you would take Tylenol or Motrin. For hot flashes, you would just dress appropriately. For vaginal dryness, get out your coconut oil and then go to the local Catholic church for your exorcism once you're done. As far as Ovidril might cause an injection site reaction. It's just a tiny little shot, and we call it the trigger shot. It sounds very, very violent. It should be called like the unicorn sparkly shot that causes you to gently ovulate. But the reality is it's called the trigger shot, and I hate that name. I wish it was something else. But it's a tiny little shot, skin in your tummy, that you can self-administer whenever your doctor tells you to. And then the Prometrium is progesterone, and it's optional. So sometimes you're making enough progesterone on your own. You don't need the supplement. But some patients still need it, even though they take the Ovidril, they're ovulating more than one egg. Sometimes they need a little something to increase their progesterone, and that might help in certain cases. But if you feel really dizzy, if you're feeling really drowsy, nauseous, that might be a sign that your natural progesterone levels are already pretty high and you don't need to take more. Okay, this next question comes from Eva, age 41, from Miami, Florida. After 8 years together, we just broke up. Okay. Eva, I'm sorry, but it might have been a good thing. Before I lose any more time, can I freeze my eggs at 41? Here are my levels. FSH 10.9, LH 3.1. I feel it's too soon after the breakup to pick a sperm donor, but I definitely want to have kids someday. Even if I wait one more year, I feel freezing an embryo does have a better chance, but rather freeze my eggs. Thank you. Love your show. So Eva, the answer is there's a couple things that I want you to do. Number one, go right to a fertility clinic and get your AMH level checked and your follicle count checked and start freezing your eggs. Go to an egg calculator. There's so many online, but the one that I love the most is the Brigham and Women's Hospital, BWH. Put in egg calculator into Google and you can play around with that. Once you see your fertility doctor will tell you how many eggs they expect to get from you at the age of 41. And you can play around with that little thingamabobby, the little program. You put in the number of eggs, and then you put in your age, and you hit enter, and it tells you what the percentage rate of pregnancy will be at your age with your eggs at the time. And then you can kind of play around the number and increase the number, and then see how many eggs it will take for you to give yourself the highest chance of having 2 live births. That's kind of what I do. I want my patients to have at least a 50% chance or more of having 2 children from their egg freezing efforts. Yes, you are right. Doing embryos would give you a much higher chance and help you, I think, more at the age of 41. But do you have to? I'm giving you the answer already. Freeze them as embryos? No. If you're not ready to pick a sperm donor, it's okay. But I think that getting your AMH checked and starting with egg freezing is just fine. And then maybe after your second cycle, you can do a 3rd cycle for embryos. This next question comes from Christy, age 31, from New Jersey. Hi, Dr. Aimee. Thank you for sharing your wealth of infertility knowledge. I'm 31. I've been trying to get pregnant since September of 2019. I was diagnosed with a hysteroscopy and had a salpingectomy via laparoscopy in November 2020. They also discovered stage 3 endometriosis. I just finished my egg retrieval and I had 25 mature eggs, 18 fertilized, 6 came back as blastocysts, and I thought was in the clear to potentially have 3 kids. But I received the grading report and it showed a day 7, 5 BC, a day 6, 6 BC, a day 7, 4 BC, another one 4 BC, day 5, 4 BB, day 6, 5 BB. Does this mean I definitely have to have another retrieval? Can you confirm that these are badly graded embryos? I'm waiting for my genetic testing report, but even if that comes back that they are all genetically normal, should I still proceed with the transfer? Thank you so much for taking the time to answer my questions. Okay, so Christy, it sounds like what you want is you want 3 kids. What is it going to take? Based on these embryos, it might take another IVF cycle. Are you willing to do it? It sounds like you are. So I would say go do it. Ask your doctor about taking HGH. Talk to your doctor about your other fallopian tube. So it sounds like you had 1 hydrosalpinx and a salpingectomy. I'm concerned that your other tube might get in the way of your IVF success. So before you transfer, ask your doctor if it makes sense to do an HSG to see if that other tube is wonky. It's not a medical term. Wonky is not a medical term. We don't use that term. but I like to use that term. It just sounds like it's a good term. So, or we'll just use the word situation. Is there a situation with the other fallopian tube that needs to be addressed before you transfer again? So that's one thing that I would ask. And then also talk about adenomyosis, because endometriosis patients also might have a higher risk of having adenomyosis, and adenomyosis might get in the way of a healthy implantation. And there's treatments for it. You don't want to talk about this stuff after you transfer your precious embryos, because it does seem like you may have enough embryos for 2 live births depending on the genetic testing results, but you might need another cycle to have 3. And I highly recommend that you do another one. And go through my mnemonic. It's embryodiamonds.com for those of you who don't know what it is. And sit down with your IVF doctor, do a post-IVF consult and say, it sounds like you know what day your embryos are. Go through the implantation rate per embryo, find out which one's abnormal, which one's mosaic, get all the official reports, including the genetic testing reports, the sperm reports, and then look at which ones are normal, ask, and it sounds like you were asking this question, will these embryos help me reach my goals and help me achieve my dreams of having 3 kids? And if the answer is yes, move on to implantation testing or embryo transfer preparation, whether your doctor thinks that's right for you or not, to test the lining of the uterus before transfer, and then move on to transfer. And then know that you've done everything right, let it go. And then I hope and pray that your transfer will be successful. And for every single person that I meet and I interact with, I want every transfer to work the first time. And I know they don't. And it really is so hard to deal with things that don't work when it comes to something that's so deeply personal and so desired. Okay, this next question comes from Robin, age 35 in New York City. Hi, Dr. Aimee. Thank you for all you do for women facing infertility issues. Your lighthearted but in-depth information has truly helped with some of the difficult feelings that have come along with my fertility issues. I'm 35 and I've been unsuccessfully trying to get pregnant for almost a year. Never pregnant. My GYN stated that I have one fibroid the size of a small, that looks like an apple, which she doesn't believe is affecting my fertility. I'm waiting for my HSG. My current BMI is 41. I've started to improve my diet and increase exercise. My question is, how would my age and weight affect my treatment options and chances of a successful live birth? I know that I'm at an early stage in this process and I have a few more steps to complete, Tushy, and I just want to know what to expect moving forward. Thank you for your time. It's appreciated more than you know. Okay, Robin, Egg Whisperer Golden Rule number 359 is, if you're over the age of 32 and you know you want to have at least 2 kids, then freeze embryos. Remember, you also might have a fertility-threatening condition. What is that? The fibroid. If your fibroid's the size of an apple right now, imagine that it could also grow in pregnancy. It can grow after pregnancy. It can grow over time. And so when you're ready to have your second baby at 37, you're going to be like, oh my gosh, I could have frozen embryos when I was 35 and I had younger, healthy eggs. So if you're in a position to do that, that's one thing that I would have you consider doing, Robin. Don't let your weight get in the way. Most IVF labs, their BMI cutoff is 40. So you're so close. You're there. You're going to be there like probably in a week. So I would make that goal one of yours as well. So go see a fertility doctor, one that will believe in your fertility, one that will celebrate everything about you and not shame you about your body size or make you feel bad about it. And I always try to use language, and I hate even talking about things like BMI because we know how inaccurate it is. I like to focus on what can we do to help you be even healthier than you already are. See, doesn't that feel good? I'm healthy, I'm strong, and I'm going to be healthier and stronger. And that's exactly how I want you to think about you, because that's how I see you. I see every single person that I meet, no matter their body size, no matter their age, literally, no matter their age. I have friends who are like 50, they're like, Aimee, I want to ask you a question. I'm like, oh my God, I'm so excited. You want to have a baby? They're like, no, that's not what I'm calling about. So anyways, I digress. So Robin, you're doing all the right stuff. Get your tissue checked. Go see a fertility doctor in New York. There are so many fabulous doctors in New York City that I know they're going to take great care of you. And if you need an introduction to one of them, call me. Okay, this next question comes from Emily in Texas. I'm 37 years old and I have a hormone question. My most recent TSH was 2.7. My fertility doctor wants it to be below 2.5. She's prescribed me Synthroid. My prolactin was high, non-fasted, and fasted state. My fasting prolactin was 25, and she said ideal is 23 or less. She prescribed meds for that and wants me to do an MRI to look for anything abnormal with the gland. What's your take? Why is prolactin important? Please help. I'm 37. So Emily, I don't want to interfere at all with your doctor's recommendations. Nope, not going to do it. However, I think this is a good time to get a second opinion. I would go to an expert in thyroid. The thyroid and the prolactin are connected. If your TSH is brought down from 2.7 to below 2.5 with a little whiff of Synthroid, your prolactin will also come down as well. It's a beautiful thing. It's a really cool thing to see. So in my opinion, your prolactin, where it is at 25, to me is perfectly normal. I don't feel like a prolactin of 25. And again, this is me talking. I am not your doctor. I'm not your treating physician. So it's important for you to talk to your doctor about this. I wouldn't take action for a prolactin of 25, especially noticing that you are on Synthroid. But talk to a thyroid specialist. So see what they have to say as well. Talk to a doctor who practices medical endocrinology. And we have a ton of doctors here in the Bay Area, and they do all telemedicine consults. And I feel like your doc will not be mad at you for asking more questions. But if anything, you can also just repeat your TSH and prolactin now that you've been on Synthroid, and chances are that your prolactin will be normal. Okay, this next question comes from Sam, age 33 in California. Hi, Dr. Aimee. I love listening to your show and wanted your expert advice regarding my condition. I'm currently awaiting an embryo transfer. I have multiple PGS tested embryos. My doctor ordered the Receptiva DX test and it's not positive. I had one chemical pregnancy and one stillbirth due to genetic issues. My husband has a chromosomal inversion. Before I started IVF, should I get treated for endometriosis although I don't have unexplained infertility or prior implantation issues just on basis of the Receptiva results? I never had symptoms of endo either. Okay, Sam, here's the deal. So look at the number of embryos you have and ask yourself how many kids you want and how does that connect, right? So if you have, you said several, but if 2 are really top notch and you want 2 more kids, then what I'm thinking is it might make sense to treat the endometriosis. If you have several, like we're talking 5 top-notch embryos, and you want 2 kids, I think it's okay to just transfer now without necessarily fully addressing the BCL6 level that you have. But there are ways that you can address it without fully addressing it. Thing 1, take N-acetylcysteine. Thing 2, you can also take letrozole. Letrozole is used off-label to also shrink endometriosis. So in someone who just feels like they just want to transfer because they have so many embryos and maybe they don't want to do Depo-Lupron or Alyssa, then what you can do is take letrozole every single day until you start progesterone in your transfer protocol. So that's a really good way of dealing with the positive Receptiva results and also treating it to give yourself a really good pregnancy rate. But I would make sure that you've looked at your fallopian tubes if you haven't recently. I know you've gotten pregnant in your uterus based on the fact that you had a pregnancy before that you mentioned that was diagnosed as sounds like abnormal because of your husband's genetic issue. But I still feel like with the Receptiva test that's positive, that could be a sign that there might be a hysteroscopy, and you definitely don't want to miss that because there's no amount of letrozole that will address that, and that could get in the way of a healthy implantation and increase the risk of an ectopic pregnancy. Okay, this next question comes from Haley, age 30, from Orange County. Hi, Dr. Aimee, BMI 21, husband's BMI is 24. He's 32 and I'm 30. Back in May of 2019, we had an ectopic and I chose surgery instead of a shot, and they found the ectopic in my left tube, but they saved it. They also diagnosed me with endometriosis. We tried again for 4 months, no luck, had an HSG, which was excruciating. The tubes were partially blocked, but they were able to open them after pushing another syringe of dye through. We tried another 9 months, no luck. We then saw a fertility doctor, and she recommended I speak with an endo specialist. Long story short, I had excision surgery December 21, 2020, and they found stage 3 endometriosis everywhere, including around my tubes. It's now been 2 cycles of letrozole and trigger where I responded great, but no luck. Normal 27-day cycle. AMH is 1.18, FSH 6, estradiol 36. Semen analysis was great. Motility 41%. Repeat HSG next week. What would you recommend we do? I'm taking NAC, CoQ10, and prenatal vitamins. So Haley, I would recommend that you create embryos, number 1, because you have tubal factory infertility and a fertility-threatening condition called endometriosis. You're also so lucky that you're 30 years old with a really good AMH at 1.1. I expect you'll probably get around 3 really strong embryos at your age. Number 2, go back and do a laparoscopy. Sure, you can do another HSG, but why? Your tubes are already screaming at you in every single HSG. Leave me alone. I mean, you had to push so hard to even get a little bit of fluid through. Imagine you close your eyes, they're going to be closed again, literally. Like, there's no such thing as you push them open. I know people are, and again, just because I'm saying this, again, doesn't mean it's true. Everyone's situation is different. So what I'm just teaching you guys about are things that I think are important for you to know, but they may not exactly apply to you if you're listening to this right now. So when someone does an HSG and the tubes are blocked and they say, oh, I had to use another, syringe of fluid to open them up, and I saw them open up, they might have been open in that time, at that time point for about a second, But after that, your fallopian tubes are likely going to be blocked again. So whenever I have a young woman, age 30, with a healthy AMH who's been trying for over a year and still can't get pregnant, especially if you have a history of an ectopic, for me, both tubes are presumed blocked until otherwise. And so in your case, I won't go in and do a laparoscopy and remove the fallopian tubes now. That's really depressing because people still have hope in their heart and they want to believe that, you know, they're one of those people that can have blocked fallopian tubes and still get pregnant naturally, right? Like we all, like that's a very natural, normal thing. So you want to wake up to something. And what you want to wake up to is your embryos. You want to wake up looking forward to bring your embryos home. And so that's why having embryos frozen first is extremely important to me for my patients who are in your situation. Okay. Oh, there she is. I did excision surgery. So they said they got almost everything out and the doctor recommended moving to IVF, but doesn't recommend I get them removed. I mean, what you could do is do your IVF cycle and then at the time of the egg retrieval, do your receptiva test. So the receptiva test will detect if whether there's inflammation coming from the tubes, and if it's positive, then remove them. But you can certainly see how many strong embryos you get in transfer 1. And then if it works, awesome, you're golden. And then if it doesn't work, then you know what work you have to do. But I don't like to, I call it rolling embryos, like rolling the dice. It's just, you know, having another ectopic pregnancy when you've already had one just seems really horrible to even think about putting you through that. So that's when I'm like, one ectopic, enough for me. Let's make those embryos and then consider removing the fallopian tubes, especially with the history that you have. And you're welcome. Okay, so this last question comes from Zara, age 33 in Illinois. In the ultrasound, I've been diagnosed with endometriosis, multiple endometriomas measuring, looks like 17 millimeters, 12 millimeters, 10 millimeters, 17 millimeters on the right and left ovaries. I also have adhesions of both ovaries, and they're kissing between ovary and uterus and adhesion in the cervix. Both uterosacral ligaments are thick. I also have a rectosigmoid nodule that's seen. Can I get pregnant naturally? I have been trying for 7 months with no success. My AMH is 1.1, FSH is 5, LH is 3.3, age is 33 and a half. I have no symptoms like pain or heavy bleeding. What would be the best infertility treatment for me? So Zara, what I would say is let's start freezing embryos. Get on N-acetylcysteine, CoQ10, and I also like NAD for egg quality. I would start freezing embryos, but talk to your doctor about what they can do to minimize the amount of estrogen that you're being exposed to so you don't worsen the endometriosis. And one way that I do that is I have patients take letrozole throughout their cycles. So that's a really cool way to keep your estrogen load down so that you're not exposed to so much estrogen, so hopefully your endometriosis won't get worse as you're going through cycles. So I would take a look at your embryos and your embryo quality and make sure you have enough embryos for the family size that you want. If your doctor hasn't done an HSG, I would strongly suggest doing that and then do the Receptiva DX test perhaps as part of your IVF cycle and then see if you should do a laparoscopy or treat your endometriosis medically with Lupron, for example, if your doctor thinks that you might have adenomyosis. So if your doctor thinks you have adenomyosis, you might as well just consider a laparoscopy and then a month or 2 of Depo-Lupron before you transfer so that you have the highest rate of transfer success and the lowest risk of having a miscarriage or preterm labor or delivery. Okay, guys, thank you so much for all the questions that you guys sent in. I really appreciate it. I have a bunch of live chatted questions here. I'm just going to kind of scroll through right here. I'm just going to start reading them out loud. And thank you guys for joining me today. Let's go to the first question here. Can you have a hysteroscopy while being suppressed with Lupron? If they'll do some intervention, do you think the lining being thin can cause further adhesions? The answer is I love the idea of doing hysteroscopies when people are on Lupron, and I do it all the time. So let's say I've had a patient on a 2-month Lupron program. I'm not going to do her hysteroscopy right here. I'm going to do it over here. And over here is right before she starts her estrogen so that I make sure that there isn't a recurrent polyp or anything inside the uterus that's going to get in my way and muck up my success rates. Next question. Hi, I love you. Love you too. I just learned that that means love you. We've done all the tests you suggest. I'm 36 and have DOR. I had a uterine polyp, but it was removed. Our main issue is male factor infertility. We did our first vet. It didn't implant help. Okay, so if you have male factor infertility, make sure you've done a sperm DNA fragmentation test. I know some people are like, oh, I don't believe in it. And I'm like, that's fine. You can go to that church, and I'll go to my church over here of I believe in science. I'm just kidding. I'm being a smart aleck. Definitely, no doubt about that when I say that. But I do feel like that in certain cases, sperm DNA fragmentation, if elevated, can decrease implantation rates and cause implantation issues. And then if you haven't already, look at the number of embryos you have, look at the embryo quality, and see if you should make more. If your AMH is, let's say, low and you've been diagnosed with DOR, this is the perfect time at 36 to make more embryos. Ask your doctor about using Pixi or Zymot, something like that, to improve the quality of your embryos if needed. The other thing I would do if you haven't already is consider doing implantation testing because I think that could be helpful. Let's see. My AMH dropped from 0.9 to 0.8 in 9 months. Is that concerning to you? How much did your AMH change in, say, a year? I'm 36 and worried. So I would say your AMH is about the same. It just kind of meanders, and that really is a normal variation. So can you take true nitrogen if you have MTHFR mutations? The answer is yes. This is a sweet coffee cup someone gave me as a gift. It says, a truly great doctor is hard to find, difficult to part with, and impossible to forget. So that was a very sweet gift someone gave me. Hi, I had an egg retrieval yesterday, and due to unexpected low sperm motility, the eggs were frozen. Will this affect quality having them frozen, thawed to fertilize, then refrozen for testing? So the answer is, at a really great lab nowadays, in this time that we're living in, frozen eggs can do just as well as embryos, right? But not all labs I can say that for, but I can say, especially in the Bay Area, that I feel really good about the frozen egg rates, the thaw survival rates, the blast formation rates, that they are very comparable to fresh eggs. And I know that I'm not the only one that is seeing that. From Stacy, last month my FSH was 13.8. This month it jumped to 20.8. What would cause it to jump this much in 1 month? So Stacy, those fluctuations are normal. Literally. I mean, like the next month it could be 12, and the next month it could be 9, and then the next month it could be 21. I mean, it's just called life. It's just the passage of time and aging. These are normal changes that we see. These are diagnostic tests that we do to guide us as far as what treatments we should consider. And then the pregnancy rate for each treatment, we use these levels to tell us what those pregnancy rates are. So I would say it's just the passage of time and your age and nothing more, nothing you can control. This next question, how bad is smoking marijuana while doing egg retrievals for embryo banking? Age 41. Please don't judge. I don't judge at all. I don't. But I would say hold off on the marijuana use until later. This is the time to get stoned on CoQ10, stoned on NAD, and you can have a glass of wine when you dine. Just no tequila because it doesn't rhyme with dine. But I would say that avoid the marijuana if you can. What's the best cycle day to start IVF stimulation days? So it just kind of depends on the protocol. Everyone's protocol is a little bit different. You can actually start randomly. You can start after ovulation. You can start at the beginning of the cycle. You can start after birth control pills. There's so many different ways to start. I took progesterone and did not induce a period. Okay, let's see here. Is a prolonged delay on start of stims normal after estrogen patch priming for 2.5 weeks? And I'm not sure when you were started, but I know with priming, it's kind of like taking birth control pills, depending on the dose of estrogen that you were on. Hi, doctor. I just did an IVF cycle on March 4th. When do you suggest I do another IVF cycle? So it just depends on how swollen your ovaries are at the time that your period starts. And then based on that, your doctor will tell you if your body can handle another IVF cycle right away or if you need a 1-month break. Let's see here. My hubby has a varicocele with a sperm count of 1 million, a motility of 36. Do we need surgery? So the way I would answer that question is this. How old are you? If, let's say, you're 27, I would say let's get his surgery done. If, let's say, you're 37, we may not have as much time. So take a look at your follicle counts, your AMH level, look at how many kids you need or need, and then, that was silly, and then do a sperm DNA fragmentation test and kind of see where things are at. And then you'll know, since he has a count of 1 million, you can still get a sperm DNA fragmentation test result. If the DNA fragmentation is high, then I would say yellow light, work on it, get the surgery. If the DNA fragmentation is low, I would say that's green light and you can go for IVF and chances are everything hopefully will be okay, despite his low quality. Okay, last month my AMH was 0.05, FSH was 20, everything else was normal except for vitamin D17. Can you explain how vitamin D affects AMH levels? Can my low vitamin D be making my AMH falsely low? And the answer is, since your FSH is high at 20, the likelihood that your vitamin D is affecting your AMH is probably pretty low. So given that your vitamin D is 17, I think taking a healthy amount of vitamin D, like 6,000 units per day, is something that I would recommend if you were a patient of mine. And then I would say, depending on your age and your follicle count, it might make sense to start doing IVF if that's something that feels comfortable for you. Next question, in my second of 4 egg retrievals, I had 4 embryos PGS tested, 2 normal, 1 abnormal, and 1 no DNA detected. Is it worth retesting that embryo or try a 5th retrieval? I'm almost 40. Embryo number 9 out of 16 worked. So my answer to your question is, the way for me to know the answer is to find out the quality of the embryo and the experience of the lab that you're with. So if the embryo quality is really good and your doctor says, yep, we have lots of great experiences thawing, biopsying, rebiopsying, refreezing embryos, and we feel like it doesn't harm your success rates, then I would say you can feel safe doing it. However, if your clinic is feeling nervous that potentially this could decrease your chance of a healthy implantation, then I would say avoid it, maybe transfer it last and still do another cycle if that's something that you want to do. This next question, I'm 36 years old. My hormone levels are perfect. Counted 26 eggs. Husband's morphology is 2%. Motility 28, quantity good. Doctor wants to do IVF and no IUI. What do you think? I've had 3 losses at 5 weeks. So I think I would definitely take advantage of doing IVF with genetic testing. I would make sure that you've both done carrier screening and chromosome analysis. I would make sure you've done an anatomy evaluation and done all the things in my angel check, like rule out antiphospholipid antibody syndrome. Next question, what age should I consider egg freezing? So I recommend that everyone considers egg freezing and knows about it by the age of 25. Doesn't mean that everyone needs to do it by the age of 25, but by the age of 32, if you want at least 2 kids, I would freeze your eggs. If you're 37, you already have 1 kid, I would go ahead and go right into embryo freezing or IVF. How common is an embryo splitting after a 5-day blastocyst and transfer? Every clinic's different, but most clinics will quote a rate around 1 in 400. But ask your clinic to see what their rate is because it differs from clinic to clinic. Hi, Dr. Aimee. When do you recommend getting the COVID-19 vaccine? I would recommend getting as soon as you can get an appointment. That's my recommendation. Hi, Dr. Aimee. In IVF, is it more common to get more female versus male embryos? Is there anything we can do if we have a preference? The answer is no. I wish. There's no I think one day there will be something, and there has been stuff out there that I call scams. They're called sex selection scams, and they're everywhere. You can just go to Facebook, you can go to Craigslist, probably not Craigslist. I just said Craigslist because it sounded like maybe on Craigslist. But there are all sorts of scams out there that you can buy. You can send your sperm places like outside this country, and they'll ship it back with only girl sperm or boy sperm. And I promise you, it's a scam because I've tried it all of it. When do you recommend, I think I already said that, before and post IVF? So I would say as soon as you can. I want everyone to get vaccinated before they get pregnant, if at all possible, or when possible. Hi, Dr. Aimee. Have you ever seen removal of the mild endo help to improve embryo quality? The answer is I have. And do you take virtual appointments? I do. Draimee.org, draimee.org is my website. draimee.org is where you can put in a contact request. Hi, Dr. Aimee, is it better to take folic acid or folate? I'm not sure that there really is much of a difference. If you have the MTHFR variant, honestly, I think even if you take folic acid, it's probably just fine. I'm not sure about black seed oil, though. That I'm not sure of. What are chances of IVF success with only a follicle count of 4? It really just depends on your age. Blast rate day 5, I seem to only get them on day 6. That's okay. Every lab is different as far as the implantation rate difference between day 5 and day 6. There are some labs that say there's no difference between day 5 and day 6. For mild focal adenomyosis, what's the best treatment before transfer? Lupron, letrozole, and for how many days? So it just depends on how much is there. You're saying it's mild, so maybe just 1 month. Depending on how many embryos you have, maybe 2 months. I always ask the question, if this transfer didn't work, what would we do differently? And if the answer is I would have done a 2nd month of the Lupron, then maybe do 2 months up front. I just transferred my one and only embryo, day 2, and today, my day 10 after transfer, I'm getting negative HPTs. My beta is Thursday, but I wonder if it's worth to continue with the meds. You know, I mean, it's so hard. I'm sorry you're going through that. You know, I would say that I would just get your blood level checked ASAP and see what it is. I don't like starting meds too early because sometimes I've seen things where the pregnancy test is negative, but the blood test is positive. Hi, Dr. Aimee. My doctor said freezing eggs is not the best option. I'm 33. She said freezing embryos instead. She believes the eggs get damaged more than sperm when it's frozen. Is that true? And the answer is, yeah. I mean, an egg cell is really hard to freeze. And if she's saying that in their lab that eggs can get damaged when it's frozen, then I would say I would listen to your doctor. I'm doing a day 3 transfer tomorrow. I had 3 eggs that fertilized. If they all make it, do I transfer all 3? I'll be 41 this month, thanks. And my answer to that is if you were a patient of mine and we had 3 embryos to transfer and you were 41 years old, I would say yes, I want to transfer all 3. Hi there, I had 1 miscarriage. I'm 30 years old as of January. My husband's 36. We're trying Progesterone Plus now. What are your thoughts on that? Ooh, I don't know what that is, but it sounds pretty fancy. Let's see here. Just started my trying to conceive journey. My proof tests were all positive. I'm 2 days late for my period, but my temperature dropped today. I'm sorry. My hubby has a varicocele with a sperm count of 1 million, motility of 36. Do you think we should do surgery? And I just think it really depends on your age. Let's see here. Okay, thoughts of dexamethasone for a fresh transfer. So I actually use Medrol 4 days before transfers for me, whether fresh or frozen. Everyone gets an option of doing it. Is it required? No. Does it really help? Not sure. but it's just something that I've always done. Last question before we go today. I just did a transfer last week and felt a little nausea, but this week I feel fine. Is it possible? Did not attach. The blastocyst went through all the tests and started to hatch on the day of the transfer. So that's the thing. These symptoms that they can come and they go, and they make you feel like it didn't work when it really worked. So I would say just wait until your pregnancy test, find ways to distract yourself, and think about a plan. So that's why I always like to talk to patients about, if this transfer didn't work, what would we do next? Because sometimes transfers don't work. A lot of times they do, especially when you go through all the steps that we talk about. And when they don't work, it's so nice to know that there's a plan in place for you so you can move forward with this plan and have something to look forward to. Let's see here. I lied. Last question. I was recently diagnosed with lean PCOS, previously believed to be secondary amenorrhea. I started Synthroid and 5 milligrams of letrozole. My LH was low all month. Usually it fluctuates. What could explain the low AMH? Well, these tests are not very accurate, so I'd say it could just be the test. And we know that LH peaks at the time of ovulation, so I would get an early, or not necessarily an early follicle check, but get a follicle check soon so that you can see what's going on. Okay, guys. Well, thank you for joining me on Ask the Egg Whisperer. You know where you're going to find me tomorrow. Maybe not tomorrow. Tomorrow I'm going to have Dr. Julie Lamb on, and we're going to talk about her egg freezing book. Let me see if I have it somewhere around here. Here it is. So I'm going to have Dr. Julie Lamb on, and her book is The Fertility Expert's Guide to Egg Freezing. It's a really great book, and we're going to talk all about it, and I hope you guys will watch. And thank you guys for being so supportive and for doing what you're doing to bring more love into this world. And I love you all, literally. And I want every single person who watches this show to be successful and to have a really smooth fertility journey and to have a healthy pregnancy. So may you all have, the clarity that you need and get your questions answered from your fertility doctors, and hopefully feel a little less alone, knowing that there are other people just like you who are going through the same stuff. And I was not going to use the word stuff. I was going to use a different word. And I think you know what word that is. Okay. Bye, everyone. Have a good night.